All right, in this explainer, we're going to break down a critical neurologic and endocrine emergency you absolutely cannot afford to miss, pituitary apoplexy. Okay, let's dive right in.
First things first, how is this patient actually going to look? Let's kick things off with a scenario you might run into on call, something that should set off all the alarm bells in your head. When you hear worst headache of my life, your brain probably jumps straight to a few big ones, right? Like a subarachnoid hemorrhage or maybe meningitis. But what else should be on that list? Well, that classic thunderclap headache is also the calling card for pituitary apoplexy. So what exactly is this? Well, it's basically a vascular catastrophe happening inside a pituitary tumor that was already there. The gland suddenly bleeds or just dies off, and the whole thing just expands. And that's the key. That sudden expansion is what unleashes this whole devastating clinical syndrome. We're not just talking about a bad headache here. It's a full-blown structural and hormonal crisis hitting all at once.
So why are the symptoms so intense, so dramatic? It all comes down to location. Location, location. The pituitary gland lives in some very, very prime, but also very crowded real estate right in the middle of your head. Let's take a closer look at the anatomy to really get why this is such a big deal. And here we go. This MRI really shows you just how packed in the pituitary is. You see it there? Just sitting below the optic chiasm, that's where all your vision pathways cross over. And it's literally sandwiched between the cavernous sinuses, which are packed with your carotid arteries and a whole bunch of important cranial nerves. The takeaway here, there is zero, and I mean zero room for swelling in this neighborhood. So when that bleed or infarction happens, the gland just balloons out. That sudden swelling stretches the dura. That's the tough covering of the brain. And bam, you get that explosive headache. If it pushes up, it crushes the optic chiasm, and that's where the vision loss comes from. You know, that classic tunnel vision. And if it decides to push out to the sides, it can paralyze the nerves that control your eye movements. It's a perfect, albeit terrifying example of how one event in a tiny, tiny space can cause a huge cascade of problems.
Okay, so you've got this patient. The story fits, your clinical suspicion is through the roof, you're thinking, this could be it. But how do you prove it? And, even more urgently, how do you figure out what's going to harm this patient first?
We don't have time to waste here. You need eyes on the sella turcica, like right now. The whole game is about visualizing that pituitary gland to see how bad the damage is and how much it's squishing everything around it.
And listen, don't just order a standard head CT, because that might actually miss it. What you need is a dedicated pituitary MRI, with and without contrast. That's the test of choice. It's going to show you everything, the bleed, the dead tissue, and most importantly, just how much it's compressing that optic chiasm.
But here's the thing, while you're getting that MRI to look at the structure, you cannot forget about the function, because the thing that's going to be a threat to your patient first isn't the headache or even the loss of vision. It's the catastrophic, sudden collapse of their entire endocrine system, and specifically the adrenal axis. So you're going to draw a whole bunch of labs, right? The full panel, to check for what we call pan-hypopituitarism, which basically means the entire gland has failed. But look at that top row. The one you really care about right now, the most critical one, is cortisol, along with an ACTH. Why? Because your patient has probably just lost their ability to create a stress response. Poof, it's gone. All right. The MRI's in the works, labs have been sent off, but you cannot, and I repeat, you cannot wait for those results to come back. The clock is ticking, loud. So what do you do right now? What are the absolute most critical, time-sensitive things you need to do? Take a look at this list. Number 1 is number 1 for a reason. You absolutely cannot delay this step. You have to assume this patient is in a full-blown adrenal crisis, and you treat them for it now, before a single lab results is back. And that treatment starts with a very important number, 100. That's 100 milligrams of hydrocortisone IV stat. Don't think, just do it. And let's be crystal clear, this isn't just some nice supportive care. This is actively life-saving. Without cortisol, the body simply can't maintain blood pressure. It just can't. So this one action, this one shot of hydrocortisone, prevents them from going into shock. It stabilizes them and buys everyone, especially neurosurgery and endocrinology, the precious time they need to do their jobs. Okay, so you've done it. You've pulled the patient back from the brink with those emergency steroids and fluids. But their journey is far from over. We've managed the immediate crisis, but what comes next is just as critical. So when do they need surgery? The decision to head to the OR is almost always about the neurologic fallout. Is their vision getting worse by the minute?
Are they becoming less and less awake? If the answer is yes, the neurosurgeons are going to go in, usually right up through the nose, to relieve that pressure and save as much vision as they possibly can.
And this really brings us to the long-term reality. Because that initial event, the apoplexy itself, and maybe even the surgery to fix it, it often wipes out what's left of the normal pituitary gland. And that means a lifetime of hormone replacement. We're talking thyroid hormone, cortisol, sex hormones, you name it. They'll have a new best friend in their endocrinologist. So let's end with this question. You've stabilized them, neurosurgery's on the case. What's the real next big decision point? It's all about looking ahead. It's not just about surviving the night, it's about systematically figuring out exactly which hormone systems are broken for good and building a lifelong plan to replace them. It's that crucial shift from a terrifying neurologic emergency to the careful, long-term management of a complex chronic endocrine disease.